I'm getting my exercise today. So at this time, I would like to invite all of our guest speakers to the front as panelists. And we're going to take questions from the audience on all that you heard this afternoon. So that's all of our speakers. And there are microphones on either side, so please, if you have a question, if you could go to the microphone. So we are recording this session for others to view later, and of course, there's folks listening in live streaming. Don't be shy. Okay. Are there any questions about any of the topics that we discussed this afternoon? I think Shelley has one. She probably has a few.
So in the session that I attended, we talked about early diagnosis, and Francine, you were here last year, so of course I brought your name up. But one of the areas that we talked about last year, and there was no further research done, was today, when looking for the amoebas, you're encouraged to heat the CSF fluid up. But there was some thoughts that were thrown out last year about just simply putting some of the CSF fluid in a petri dish of water where they would end up possibly swimming in easier detection. So that may not be something that you can yet answer, but when we look at research, I guess that would be something that would be something we would want to add to the list to see if that's still possible or that would still be a recommendation.
I think the question was, it was hard to hear, I'm sorry.
Oh, I'm sorry, let me try again. So I won't repeat all of that. The audience will appreciate that. But Francine, last year when you were here, right, we talked about early detection of the amoeba. And today, a lot of the lab techs are taught, if they can't see it, to possibly heat up the CSF fluid. Your suggestion last year, and I don't think we really followed through to any degree to see if it's possible, was why couldn't you simply put some of the CSF fluid in water, and would it be that then the amoeba would easily or less be able to be identified earlier or easier? So I'm not sure that you have an answer for that since we didn't do much since last year, but I'm thinking it's a great topic to put in the research category. And if you have thoughts on it, I'd certainly like to hear more. Thank you.
Okay. I'll try to do my best. Actually, early studies showed, it was important to put the amoeba in water because when you put the amoeba in water from like CSF or even a media or whatever you're growing it in, it will inflagellate. It gets hungry and it inflagellates and swims to the surface. So if you saw a few amoebas in your dish and you put water in there, because the amoeba should stay attached to the plastic dish or whatever they're in, that you're growing them in, and they should stay attached. And if you put water in there and wait a little bit, I don't mean immediately, but in a couple of minutes, 10 minutes, 15 minutes, you could see them start to inflagellate and swim to the surface. So it would be, I think it's not a bad idea to try putting water in just to help to identify them. The other thing, I mentioned it in our little session for laboratory technicians, the nucleus of an amoeba is very distinct. It has a very large nucleolus that's like a black dot in the center of the nucleus. So if you take, and I believe it was one of Jennifer's slides this morning, she showed like lymphocytes and so forth, and there was one amoeba in between. If you look at that amoeba closely, you'll see it has a distinct nucleus, and that should help identify it and separate it from any of the other blood cells or CSF cells that are present. So maybe you could keep that in mind you're a laboratory technician or you're working with one, look for that distinct nucleus and look for flagellates.
Would putting a drop of saline on a slide or water on a slide and then taking CSF on a slide and look at that would work just as well?
Well, I mean, it's not going to happen. It's not going to happen immediately,
Sure.
but it will happen in a little bit. I wouldn't put them in saline though, because water.
Just regular
water. Yeah, because they
tap
don't
water?
like saline too much.
Okay, that's learned that today.
That's
okay.
why we want to squirt saline up the nose.
Gotcha. Okay.
Could you go to the microphone for us? Where? Right over there.
I just have a question about, there is any particular patients that they have a risk factor to get this amoeba from the nose? For example, patients who do have allergic rhinitis, turbinates are enlarged, erythematose, and some of these patients, they do have epistaxis, means nose bleeding. There is any study who shows that this patient who have been getting this amoeba, getting it from the nose, that could be a risk factor?
Go ahead. You go.
The answer to that, at least from my standpoint, is that we don't know. It's not something we've been able to establish. Most cases, as we've all heard, are healthy teenagers, healthy children, healthy adults. So there's not an obvious risk factor as far as anatomy or predisposing condition that predisposes them to PAM. I don't know if others, but that's been what based on the data that we've collected at CDC and then that's out in the literature, that we don't think there is any predisposing factors.
I could just mention, I have a hard time hearing the questions, but if you're asking about risk factors, there were some papers published on low levels of an immunoglobulin in the mucus in your nose. That's IgA. So if you have a low level of that, that could maybe be important. Let's see what else, that you got infected with. It's not that you're more susceptible, but that you got exposed to a very virulent form of the amoeba. We know that some animals in nature have been infected, and when they die, that amoeba goes out into the water or into the area. And once the amoeba passes through animals, it's much more pathogenic than if it hasn't been through an animal, or it had bacteria. When they eat some very pathogenic bacteria, the amoeba do. If you got infected with an amoeba that had a lot of bacteria in it, that's even more pathogenic. So those are factors that could affect it. But that's all we know. We don't know very much, to be honest.
This question is actually for Dr. Kyle. The conference that you indicated that you and Dr. Ali, I believe, are going to attend, I was just curious as to where that conference is located and when.
It's an annual conference of the American Society of Tropical Medicine and Hygiene. This brings together microbiologists, parasitologists, infectious disease docs, travel docs, as well as an international audience. It's usually in the fall of every year. This year it's going to be in Atlanta in the middle of November, and I just got notification last night that our symposium is the morning of November 16th. So it's a way for us to inform that community as well.
Is that live streamed by chance?
It's not usually live streamed, but some of the events are recorded. Yes, and I can find out if that if our part can be recorded for people.
I think I'll take a go. I've got about 35 questions here. So I know we've talked about different temperatures where the amoeba is active in the flagellate stage and can actually be infectious. I know we've removed the low-end temperature off the CDC site. It doesn't list it anymore. We get questions all the time on what is the temperature range and when should we be concerned. Do we have a definitive high-end number that it doesn't have to go into cyst form? And what would be the low-end temperature that people should be concerned with? I'll offer it up to anybody that wants to take a chance.
Well, we discussed that briefly in the research part, and you may not like the answer. We don't know a lot of this. Some people get confused about body temperature is 37 degrees C, and you lower the temperature of a patient down to 33. That may slow the amoeba, but we grow Naegleria fowleri at 33 degrees in the lab all the time. It grows very, very well. So it may slow the parasite a little bit, but it's not going to make it insist by doing that. But we don't even know the basics, Steve, if a cyst can actually be infective. There's not a good study that I know of that really defines if a cyst can get into the nose and exist and become an amoeba, or if a flagellated form gets inhaled, if it's infective. So there's some very basic questions that we don't know. And I think this whole question about why some people get infected and others don't is a really potentially important question that a research community could apply some of the new data that's coming out of Ibni's lab and some good approaches, and we could start to understand that.
Are we on? There we go. Okay, so that leads to my next question. How do we determine research in that area? I don't think we listed it on any of ours. Do you see any need to go into research in that to understand it better, to know what the infectious temperatures are, or no?
We would love to have the ability to do a wide swath of sampling across the country in various types of natural water bodies and collect even some very basic water quality data from each of those sites. We are exploring opportunities with the U.S. Geological Survey, which that's what they do. They sample water and soil around the country from all different kinds of sites. So, in fact, you might have heard the reports about finding Naegleria in some of the hot springs out in Wyoming. And that's some work that they're doing and that we're working with or helping them do that work. And so, we're continuing to have discussions. They do national water surveys where they're constantly taking samples. We'd love to get Naegleria on that list of things that they're testing for, because we really don't have a good idea about just some very basic things. Where is Naegleria found? At what temperatures? What times of year? I mean, we just have these very small pockets of data that have been done, as we said, mostly in response to cases, and some smaller areas of research in specific pockets around the country. So I don't know if there.
Sorry. Is there money available for that research, or is that something some of the foundations can work towards?
We talked about that. As far as I know, EPA or other sources for environmental testing are not supporting any work like that. So any scientist can come up with a proposal and put it to NSF or NIH and try to get funding, but it's been very minimal for this disease. I'm very fortunate. Our lab has now been supported a couple of times with small grants from NIH, and we can make a lot out of that. So I think if we put this forward in what the key components of a research agenda would be, then we can start telling people. But I know NIH is very receptive. When I've talked to them, they want to see more people working on it, but there's not many people that actually submit proposals to do this sort of work. But
okay, thank you.
Dr. Kyle, I know that I sat in on your session with Dr. Cabral and Dr. Lee. Do you want to talk a little bit about the studies that you're currently doing which you mentioned, with the pools of samples that you have.
I'm not sure I remember which one you're talking
Okay. The antimalarial drugs.
Well, I think what she's referring to is we've used these high throughput screens to now go through. It's like finding a needle in a haystack. So we have a bigger haystack we can screen through. We find active compounds, and so drug discovery is a business of failure. Most of the time you fail. So the idea is you have a lot of different starting points, and you push it forward as fast as you can and find out which ones can be successful. So we're really excited about one series. It's looking really good. We still have a lot of hurdles, but we know that the chances are it can fail. So we've been identifying a lot of different chemical starting points, getting more and more chemists involved, and hopefully some of these are going to come through, either for treating Naegleria infections across the CNS, but if we can't, we already have some compounds that are really active against the Canthamoeba that could be used for keratitis and other indications. So this is the sort of thing that research identity can happen. And I think one of the things that we were asked to talk about, we didn't really get into in the research, was what would be the research that's most important that could prevent the next case of PAM? And I think that's a different question than just what research needs to be done. Very, very few people understand that very basic work often leads to the basis for making the big studies that happen with the new interventions. So there's some level of research that needs to go on at a higher level just to get us to that point with this disease. I work on malaria. It's the most important parasite of man because 1 million people die a year, or maybe less than that now. There are thousands of labs doing what I do. But what we do for Naegleria, there's only 3 or 4. That's the scale of difference. We need to change the balance on that.
Sorry. I have one question for the CDC. Since the amoeba seems to be prevalent in the summer, is it any possibility that the CDC will sort of try to advertise or promote, amoeba awareness during the summertime, kind of like the flu season in the winter? Something like that?
That's something we would certainly be interested in doing. I think it's something that the Florida Department of Health has done. We have a major push in the group that I work with around Memorial Day. We kick off health, what do we call it now? Healthy and Safe Swimming Week. And so that focuses on a variety of risks that occur when people start heading out to pools and lakes and everything. And so I think messages about Naegleria would fit well during that time period.
I just have a general question for maybe Dennis or any other professors at the college level. Is there a way to get, well, I know the funding is minimal, but is there a way to get it down to a collegiate level? Coming from a school, I had some microbiology, zooplankton. My advisor was in that sort of area, and actually I think he did bring up Naegleria. And is there a way to push this down to a collegiate level, send out emails to that type of department in college levels to get their undergraduates to do any kind of studies about these organisms to kind of maybe spread it down to that level, and locally or nationally or globally, to maybe spread more awareness and maybe eventually get more funding?
Even though I'm at the medical school giving lectures, to the graduates and medical students in dental, I always go down to the undergraduate school and I give a lecture there. And it's always about just amoebas, okay? And the students are very fascinated. Most of them had never heard about it. Now they're beginning to hear about it more, and they get very excited. It's amazing. I mean, they email me and say, please can I come and be in your lab for a little while and learn how to work with that, and what is it? I mean, they really want to know now. They are trying to learn. And whenever someone like that expresses such a great desire, I say, please come, because, it's just nice to have students who are excited and want to learn, and they're so excited about it that it makes you feel happy that you can at least, give something back. So, yes, if you go to the undergraduate schools and you talk about brain-eating amoebas, then, yeah, they get really excited. And I always show scanning electron micrographs. These are the ones where you can see the food cups that look like big suckers on the, face, and show them, and the students are like, wow, I never heard of that before. So that's what you can do. Just go to the younger students and talk.
Thank you.
I give a yearly lecture to a local high school for their Introduction to Medicine class of juniors and seniors. And so I do a series of case vignettes, and one of them is Pam. And yes, it does really stimulate a lot of interest and questions.
The Jones High School class spent 2 days working on these posters, and they were fascinated, and they all want health careers.
I have a question. A few years ago, I read something about some vaccine work or immunology work done with Naegleria and mouse models. Is there anything that has come of that? Does anybody know about that in terms of prevention efforts, intranasal or?
I can make a comment. I'll try to make a small, short comment. I don't know what the vaccine work was, but usually we think about vaccines and stimulating an antibody response. Several years ago, some researchers had done work where they showed that if antibodies are made to the amoeba and they attach to the surface of the amoeba ingests those antibodies and degrades them. So it's very difficult to make a vaccine in terms that one that would stimulate an antibody response. And the other thing is an antibody plus complement. Usually you get a cytotoxic reaction. You kill organisms if you have antibodies plus complement, which is a blood protein, serum protein. But the amoeba, they don't. The amoeba seem to be somewhat resistant to complement-mediated lysis, too. So we're dealing with an organism that's going to take a lot of drug discovery, Dennis, to try to wipe them out. But we're all trying, really.
I think, and this is just from Google, there were some mouse studies in like 2009 and 2012. But that was my question is does anybody know of anything that's ongoing, CDC or anybody? No, probably just research.
I have another question. This is a question I know when we look at the slides from the CDC, it's all US based. But we know that there are a lot of cases also taking place in other countries. And I have to believe that as we spread awareness globally, that there would be lessons learned and some amazing doctors across the world that we could work with. And with the recent impact that Florida Hospital has had, I also know, because I have the pleasure of working with them in my career, that you do a lot of training across the globe. So is there any potential opportunities to do more training where you might save other lives in other countries?
Well, I'll take that as a cue for the idea of a center of excellence here in Florida. It can build on what's already occurred within this state. So you have research enterprise, which is going on in Tampa. You have clinical enterprise, which is going on here in Orlando. We know that there's a plethora of waterborne disease in our area. We know that Emory has a large grant for waterborne disease. We know that Florida Hospital has a footprint not only across the United States with their Adventist health system, but also a global presence, as well as a mission outreach with health professions across the globe. So you have the underpinnings of a potential network. And Florida Hospital itself has its own training capacity, Adventist Health System University, if I'm giving the name correctly. So you have University of Central Florida that has a global presence. You have Adventist Health University that has a presence. There's a lot of potential here, Shelley, if I understand your question correctly.
I can share a little bit about what we've done internationally. I think, you know, we've heard about Pakistan, and that's an area in Karachi where they've identified several cases over the years. That's another example of a place that has had training and awareness of this infection. Again, it comes back to Vish back in the day, where he had some scientists from the Aga Khan University in Karachi, Pakistan, come over and visit his lab, and he was able to train them to identify the amoeba. And they went back, and that's why they know about it and why they can diagnose it. I think the challenge in a lot of the developing world is they're wrestling with a lot of diseases and infections, and wrestling with diagnosing and treating them. And so for them, unfortunately, PAM is just another in a long list of things that they're having to wrestle with. So we do think that PAM is a worldwide infection, probably, particularly in the developing and warmer areas of the world, and it's just been that it's not something that's diagnosed. And then Ibne can talk a little bit about going to Bangladesh.
Yeah, so I went to Bangladesh last year, and I tried to train laboratorians at ICDDRB, International Center for Diarrheal Disease Research, and they are now trained, and if there are any cases, they should be able to identify them. But because they are also dealing with lots of other infectious diseases, PAM is not like in their top in the list, but they are already trained. So we'll see like if they can identify any PAM. I don't see any reason why not, because it has been found in Pakistan and India, so there should be some in Bangladesh too.
So I know we've all agreed there's been very little study done on the amoeba. There's a lot that we don't know, very little that we do. In most cases, when a patient presents to the ED, it's determined they either have some type of meningitis, viral or bacterial. In most cases, they're given an antibiotic in case it is bacterial, and the culture is turned positive in a few days. Do we know if by giving the antibiotic it makes it more virulent because you're taking away its natural food source? Has there been any study done on that?
No.
Is that a good area to take a look at? Or are we more worried about early detection and proper treatment? Or so I'm just wondering if we make it worse with antibiotics.
You know, I think you have to put the cart before the horse. And in this instance, the bacterial meningitis is the horse. You know, it's the one that's going to be the greater predominant factor. So the ER physician is going to choose ceftriaxone and so forth as their choice for bacterial meningitis until they prove that it is something else. I think that the money is on developing rapid technologies that can assist the early rapid diagnosis, Steve, and that we would have the ability to do ELISA or to do PCR or to have laboratory technicians that are brought up to speed for light microscopy to identify Naegleria as opposed to white blood cells. You know, these things that we've already talked about this morning are where the bread and butter of making an earlier, better diagnosis of Naegleria are going to be. And that, you know, some of these research questions are great, and I think what needs to happen as far as a research agenda is those that are focused on the research agenda would be wise to create, and there is such the work group that Dennis heads, a prioritization process, you know, a matrix where they can look at what is the next steps, what are the next steps that need to be approached. And we're raising a lot of research questions here. In fact, most of this discussion is focused on the research questions. But I think it's those people who are looking at the research questions that are best equipped to help focus what the next research agenda is. Some of it's based on the literature. Some of it's actually got to be based on the world's literature, and to make sure we have English translation of what is being learned in the rest of the world. I'm not sure all of that is done for Naegleria, since we know that we have a limited body of knowledge in this country or in the Western Hemisphere. There may be other translations that are out there that we haven't really had a chance to look at. So whenever you ask a research question, you have to do the literature search first, and then that leads you to more research questions. But it's the researchers, would you agree with this, that are best equipped to help focus the research agenda?
Many times, but I think I'm a basic researcher at heart, and I think it's always very helpful to have somebody who's treating the patient remind that person what are the key objectives to actually preventing or treating a case. So I think prioritizing the research would be good. And for an example, I heard one of the discussions this morning, voriconazole is more active, and that's more active in our hands than fluconazole, but it's not really being used. What level of evidence is needed to make those sort of decisions that tilt the balance towards maybe that can go forward? So I'd love to hear some of those sort of discussions to help inform the research agenda. And the other basic question, I'm supposed to be an expert, but I'm going to still ask the question. Can we give other drugs besides amphotericin intrathecally? If there's an IV formulation of another azole, could we give that intrathecally and maybe have a better outcome? These sort of things are basic knowledge that would help us in our discovery efforts.
I believe the miconazole was given intrathecally in the 1978 case. I'm not sure.
Yes, it was.
Yeah, I'm not sure why we don't do that anymore. And I did tell Dr. Jordan he could go ahead and try voriconazole in the next case.
I was thinking the same thing when Dr. Jordan was, describing that data on the voriconazole. This isn't the kind of problem where you're going to be able to design placebo-controlled studies to show one drug better than another. It's just somebody trying it. And if they have a good outcome with the 10 different drugs they were put on, we figure, okay, well, that needs to be in the panel of therapy, the compendium of therapy. And that's why we have our current standard that includes fluconazole. So should the next case use voriconazole instead of fluconazole and everything else? It sounds reasonable, and no one's going to be able to cite evidence to say that's the appropriate thing to do. Someone's just going to do it and see if that patient survives or not.
Well, this is a different kind of evidence, but in the tissue culture dish, fluconazole is nowhere near as effective as voriconazole. And we could do animal studies to back that up with the mouse model. Yeah. These are the sort of things I was talking about, rapidly in between. If you were thinking about voriconazole or another drug that we could repurpose, How would you test that, and how would you give the evidence so that the next case does have more options?
Thank you.
So we're getting ready to close in on the panel discussion, but I wanted to open it up to you all. Do you have anything that you would like to impart on us that you feel is top of the list that we should look at for the next 6 months, 1 year before we meet again?
In our discussion of early detection and treatment, I felt our discussion about the question to open up the dialogue if this is actually what we're going to go for as a diagnosis is imperative, and how to word that question. And I think that's one thing that we're going to work on hard, and then get that into the care pathway and work digitally to do that. I believe we all know education is the key to success in this, and getting our frontline providers that information, and keep on doing this every 6 months, 3 months. This is not just a 1 year thing. And then going to all the colleges, all the different places, and disseminating that. That's going to be, I think, a very important thing that we need to do here.
I completely agree with Dr. Valenti on that point. I think that, having early diagnostic tests available for the ED is going to be critical, because it's those first few hours, the first day or two, that's going to make the critical difference between allowing the brain swelling to occur and brain damage to occur versus the reversibility of this disease. That being said, I think the other key point, short of having the ELISA test or whatever mousetrap, adding the multiplex Naegleria PCR into the multiplex, you can also look at a rapid training technique for laboratory technicians. It could be a train the trainer as a low-hanging fruit. It could be an online training to look at what Dr. Cabral has mentioned, the nucleolus that's very dense in the nucleoli, which will be the nucleus of the amoeba, which is going to be different than the leukocyte, the white blood cell. Something very basic that the lab technicians can look at and say, oh my goodness, and the care pathway that says, was this child exposed to water, fresh water? And having that connectivity between the fresh water and the dense nucleolus. I think if we get this into the brain of the lab technicians, as happened here last year, this could be a breakthrough. So, if you want to have online training, a webinar that gets pushed out across the country to those people who train lab techs, think of how many, if there are 900,000 physicians in the country, there's probably more. There's that many hundreds of thousands of more laboratory technicians. That's how many you'd have to reach to get this job done. That's a lot. But you can start with the ones who train them. And that's just a thought.
Our Care Path group will address the question of whether the Naegleria PCR can be added to the commonly used CSF multiplex PCRs. I already sent an email to the manufacturer a couple days ago asking if they would add it.
Sometimes it's as simple as asking the question. It can be.
So my question is just now, with the recent advance in case with Impovado, how many hospitals are actually going to be stocking that, and how quick are we going to get these into all Florida hospitals?
He works in my lab, so I can interpret. He's asking about miltefosine and its distribution in different hospitals. And so how fast is that going to, and how broad is it going to be distributed? Can anybody comment?
Yeah, we talked about that in our group, distribution of miltefosine. I think it seems to be a relatively new development where it's not only become commercially available, but easily available. And so one of the goals of our group, our second major goal, is to start contacting pharmacy directors around the state. We first have to discover the most efficient way of doing that. That we think that there are some networks that can do that relatively easily to promote stocking this drug and telling them how easy it is to stock and how inexpensive it is. So yeah, that was our second priority right after care path development.
And how broadly accepted now is this new care path outside of Florida? Is that a problem? Asking the basic question if water exposure, those sort of...
The presentations and few discussions I've had in the infectious disease community is that the new protocol is standard and no one's going to try anything different for now.
Does anyone have any more questions for our panelists? Okay.
Oh, by the way, here's the number of lab techs, if this is right. 2014, there were 320,200.
Wow.
That's how many we'd have to provide online training to if we wanted to reach all of them.
So I want to thank the panelists. Thank you so much. Every time we meet, I learn something new. And my hopes, just as mentioned before, is that we continue these discussions more frequently. After today, I am very confident that's going to happen. So thank you all. And I've identified the champions who are going to take the lead here, right? Because you all are champions. And so at this time, Shelley, I was going to invite you up. Shelley is going to talk to you about, and you all are welcome to stay if you want. She's going to talk to you about the call to action, what we're going to do moving forward, and the Spark Room that we spoke of earlier today and how that works. So Shelley, I'm going to turn it over to you.
Testing? Yep, okay. So, Steve, do you want to come up wherever you are? I think the first thing that I would like to do is to really just thank Florida Hospital for Children for providing this amazing venue. There's nothing like meeting in a church when you have a mission, so praise God for that. I really want to thank as well Donna Walsh, Jack, Dr. Sherritt. I don't think Dr. Jett is still here, but the amount of support, and I know that Donna's employees said it well, they've gone through a lot to support our organization, to always be here for us. And if it wasn't for their amazing work, putting agendas together and helping us organize, this event would never have happened. So thank you. Donna, could you, Jack, if he's still here, Dr. Sherritt, could you guys all stand up for a round of applause, please? And this event wouldn't be possible without all the amazing people that come to support. So could the members of the CDC stand up? Could we have Dr. Cabral stand up? And all of the amazing Dr. Demois, if you could stand up. Dr. Kyle, for a round of applause, please. Thank you. And there's a very special group I want to thank, and they're sitting right here in front of me, and they support us every day. And that's our amazing board and our amazing friends that pick us up when we're so down. They're there to support every one of our foundation events, whether it's our golf tournaments, our walks, whatever we do. And we are so blessed to be loved by so many. So thank you so much to all of our board members and our family members. I also want to thank Sandy and Tim Gump for coming out, and I would also like to thank, we have PJ and her husband here, they lost their daughter as well to an amoeba. Our goal is to actually grow and have more of the families come out and team together to make a larger voice. So I want to thank them for coming out. These are really tough events to do. 1 minute, I promise to give you the mic. And there's a really special gentleman who's in the back of the room who has pulled all the audiovisual together, who has brought tables back and forth and done all kinds of things. His name is Chad, and he deserves a big round of applause from the audience, please. I wanted to wrap up my messages really pretty simple. When we did the media release today, we're always asked, whether it's by our family, our friends, or the media, why do you do this? You have to get up and relive Jordan's death every single day. That's gotta be so painful. And we do it because we wanna save other children and family from going through what we've been through. It would be really easy to wait for the next family to come along and do it. But that's not what we wanted to do. And there's a song that I wanna know if anybody knows. It's called Do Something. It's a Christian song by Matthew West. And I had to write it down because I want to make sure I don't mess up the words. I'm not always great at speaking in front of a large group. But the song talks about, if not us, then who? And if not me and you. And what I really like is he asked God, he said, there's so many terrible things happening in this world. Why don't you do something? And then God responds, I did. I created you. So that means all of us. So my message is really that we cannot do this alone. And for those who have come and learned something today, and you take valuable information, please bring awareness to everyone you know. We have a foundation. We'd love to have volunteers. Please visit our foundation page. There's sponsorship opportunities. There's opportunities to volunteer. We need your help, and especially to the medical community. We really need you to get involved in these groups and to help us, because you have the level of expertise that we do not. So I'm going to go ahead and turn it back over to Steve. Thank you, everyone, for being here today.
So where do we go from here? Well, it's obvious we have to keep moving the ball forward, and we have more people here this year than we did last year, and we have a great story to tell right now. So we're going to ask for your support and help as we go forward. Jack's reminded me twice today to make sure I mentioned that we're thinking of moving this to the spring. I have to check with Dr. Whitehound to see if we can pull that off. But we'd like to move this to the spring before the hot months. So we're probably going to be looking at April or May of next year. The video that you saw of Sebastian and his mom, that was provided by Cisco over our Spark client. And that is the piece of technology that we're going to use to keep everybody connected going forward. It's going to allow us to send an email to you, invite you to download the client. You're going to be able to share things with everybody in the group. And you can accelerate to a video call if they're online. So we'll be sending that out to all the participants that are going to be pulling this information together to keep you connected over the next 6 months as we move towards May for next year's summit. If we need to do a training class on that, we will. So no problems there, don't worry. These last 12 months have been better than the first 12 months. And now that we have a good outcome to stand behind and to give us hope going forward, which is, if you ask Tim and Sandy and PJ and, I'm sorry, I forgot your husband's name. If you ask them, they'll say, most days we have no hope. We know what happened to our child. And we just don't want anybody else joining our group. So what happened in Sebastian's case has given us hope that we can find a cure and that we can save. I don't want to see 97 or 99% fatality rate on it. I want to see it as low as we can make it go. And that takes all of us doing a concerted effort to move forward. We heard some great ideas today that we didn't hear last year. So we just need to follow up on some of those and find out what is the best direction to go. And I think all of us working together can actually make a difference. And that's what Shelley and I are asking for all of you to help us. Let's make a difference and let's save more children. Thank you.